We're extremely privileged to have Dr. Aseem Malhotra speak to us on this online health summit. Dr. Malhotra has recently been classified as one of the top 10 young brains in Britain. He is a cardiologist who doesn't believe that a high-fat diet will kill you in terms of increasing your risk of heart disease. He's also very active in promoting this low-carbohydrate diet. In this lecture, he addresses dietary change in the context of modern medicine.
Thank you, Tim, for that introduction. I don't think I deserve any of those accolades, but it's a real pleasure to be here today to speak to all of you, and thank you for coming in early on a Saturday morning when many of you could be having a lie-in, so I'm very delighted to be here. So I think I'm going to start really by talking about, my talk is about the impact of diet in modern healthcare, but I'm going to start talking about modern healthcare first, and what I'd like to say is that currently we have an epidemic of misinformation for both doctors and patients. And I describe there are 7 sins that contribute to this epidemic of misinformation. The first one is biased funding of research. And that's research that's funded because it is likely to be profitable, not because it benefits patients. Secondly, we then have biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, commercial conflicts of interest, defensive medicine, and medical curricula that fail to teach doctors how to comprehend and communicate health statistics. Financial conflicts of interest, there's a culture to do more. And that happens because there's a financial incentive to do more investigations and more procedures and put profits before patients quite often. In the United States, for a minority, greed smothers the conscience. So one cardiologist was jailed for ordering $19 million worth of unnecessary investigations and procedures. Is that just the tip of the iceberg? Part of this issue is because of the system. There's a fee-for-service model in the US healthcare system that contributes to this overuse. In the UK, we also have something called payment by results, which in reality is payment by activity. And just looking at coronary stenting, so this is what I'm trained to do. And there's no doubt that people having stents during a heart attack is a life-saving procedure. But many people have stents done electively. They have diagnosed coronary artery disease and they'll have a stent put in. And it's been calculated in the United States that unnecessary stenting is costing around $2.4 billion per year. Around half of those stents were of questionable value. And one of the reasons for this is because we have very good randomized controlled trial evidence that tells us that stenting patients for stable coronary artery disease does not improve your prognosis, it does not prevent you having a heart attack, and it does not prolong your life. Yet, 88% of patients think they're having a stent for that very purpose. Interestingly, and this is about the culture to do more a little, 43% of cardiologists anonymously, when asked, said they would still go ahead and do the procedure even if they themselves believed it wouldn't benefit the patient. Think about that for a second. I mean, it's really quite staggering. And there are obviously other drivers of technological imperative. New technology comes in, this doing more is better based upon these exciting new devices, and I'll talk about that in a second. So the technological drive. So we've had something we've used for decades in cardiology called intra-aortic balloon pumps. And they were designed to treat patients who have the worst type of heart attacks, who have cardiogenic shock, who are the sickest patients. And we've used them for a long time. Just to give you a bit of background, we use them based upon observational studies that were industry-sponsored. Each pump costs around £40,000. A catheter per patient is about £800. There's about 140,000 used worldwide in 2012. And there's still a potential harm to the patient as well as a financial cost. Rarely it does happen, and I've seen it happen where the device itself can cause a stroke, a significant hematoma, kidney failure, even limb amputation has been reported. In 2012, we get a robust first randomized controlled trial, the gold standard of evidence, published in the New England Journal of Medicine that says this does not have any benefit in reducing mortality at 30 days or 1 year. Basically, the reason we were putting in, no benefit. You could argue this is basically just junk, A thrombectomy catheter, this is something else that we've used more recently. It's very safe, and this is something we pass down the coronary arteries when people have a heart attack to remove clot. And it sounded great when it was introduced. And then an RCT comes out, independent of industry, and shows it's no benefit. In 2012, just this device alone was costing the NHS approximately £700,000. That's just a few devices in the NHS. So the question is, can we improve a system that allows the introduction of new devices and technology for greater value to minimize any harms? And we need more transparency with patients and informed consent. So I wrote about this, actually all of this, in 2 articles. The first one was in the British Medical Journal, an editorial, and this was based upon the fact that the former president of the United States, George Bush, received a stent. And he didn't even have any symptoms. And this got widely reported in the US media, and why did this happen? And the question is, did George Bush know that he was having a stent done that wasn't going to improve his prognosis? I doubt it, to be honest. And then a little bit later, I wrote an editorial in JAMA Internal Medicine, and I basically said that one of the ways that we could wind back from these harms, be more honest and transparent with our patients, is actually put it on the consent form. So, the question I asked is, why don't we make it mandatory that when we consent patients for this procedure, we're explicit with them, we tell them it's not going to improve their prognosis. Now, it will help the quality of life in many patients who have limiting angina pain. But even the evidence for that after 1 year versus medical therapy isn't that strong. But also, and this is in my own experience, this will reduce patient anxiety and reassure them that the medical therapy they're on will protect them from a heart attack, will prolong their life, and also encourage a more informed discussion about healthy lifestyle, which I'll come on to a little bit later in the talk. And, there's no doubt this procedure, when we do consent patients, we do tell them that there's a 1% chance it could cause them to have a heart attack, stroke, or death. So this is not a completely safe procedure. It's relatively safe, but not completely so. And I've seen it happen in my career, and I've done thousands of angiograms, hundreds of angioplasties. It does happen. Interestingly, and I didn't predict this, a few months later, JAMA Internal Medicine then published a study where they looked at what happens, what would the patient decide if they were given this information. And actually, it did make a difference. So if patients weren't told about the lack of prognostic benefit, around 70% of them would go ahead and have the procedure. And when they were told there wasn't a prognostic benefit, that was reduced to 45%, which is fascinating. And it was actually calculated that if this was introduced in the States, just from a conversation, an extra conversation, which I have with my patients, that maybe take 30 seconds longer in the consultation to tell them this, that would save around $850 million per year in the US just from that conversation in healthcare. And this is in the background of the fact that we know 1/3 of all healthcare activity in the United States brings no benefit to the patient. And this is a healthcare system that by 2020 is going to be costing $4.2 trillion. $4.2 trillion. So this culture that more is better that we have. In the United States, we know that areas which have high utilization and expensive care actually have worse mortality outcomes, lower perceived access, and less patient satisfaction. And that's driven by a number of factors: greater frequency of physician visits, more frequent use of specialist consultations, more frequent tests, and greater use of hospital and intensive care spending in high-spending regions. And just briefly talk about end-of-life care. I mean, that's a very big ip at the moment with an aging population and how we should manage people at the end of their life. It's estimated about 2 million elderly care beneficiaries. Of those in 2008, about a third of them underwent an inpatient surgical procedure during their last year of life, and even 8% in their last week of life. There's something we've got to think about here. And I agree with Jack Wenberg, who's a big researcher on unwarranted healthcare in America. And he says, getting beyond the more is better assumption will require a national debate on the limitation of medicine's power to heal and cure and on the quality of care at the end of life. Okay, this is an issue which I'm very interested in, and I think is a huge area. So statistical risk and health illiteracy. So an inability to understand health statistics amongst the lay public is not surprising. Doctors find themselves often having to curb unrealistic expectations from patients. In 1995, the British Committee on the Safety of Medicines reported that the oral contraceptive pill, the third-generation oral contraceptive pill, doubled the risk of thrombosis, therefore increasing the risk 100%. This was extensively reported in the media. What was the reality of those stats? The reality was that this was just an increase in risk from 1 in 7,000 to 2 in 7,000. So the absolute risk increase was only 1 in 7,000, but that was reported a doubling of risk, 100% increase in risk. What impact did that have? It was estimated because of this pill scare, there were 13,000 additional abortions that took place the following year, costing the NHS £4 to £6 million. Doctors' understanding of health statistics is also a risk factor for misinformation, and I admit I would have been one of these people a few years ago, and I'll allude to why that is in a minute. But many doctors' understanding of health statistics and therefore can misunderstand them, therefore cannot evaluate evidence for and against a treatment. A study of 150 gynecologists several years ago revealed 1/3 thought that the 25% risk reduction created by breast cancer screening, they misunderstood it. In fact, most of them thought that this 25% reduction in risk meant that for every 1,000 women screened, 250 fewer would die of breast cancer. What's the reality? Well, the best evidence actually suggests that you need to screen 2,000 females to save one life. And there was also a lack of understanding about the harms of breast cancer screening. So for every one woman that is saved from breast cancer screening diagnosing cancer, 10 women will receive an overtreatment. They will have an operation that they didn't need. So there's many ways of actually presenting a benefit: relative risk reduction, absolute risk, or numbers needed to treat. And communicating relative risk as opposed to absolute risk, or the NNT, actually is a common way of misleading without actually lying. And it's unintentional. And therefore, what happens is we over-exaggerate in our own heads and overestimate the benefits of medical interventions. So I'll give you an example of this. So if we take a high-risk type 2 diabetic patient who's on a statin, the relative risk reduction of having a stroke is 48% over 4 years. That sounds quite strong, quite dramatic. But actually, the reality is this is actually an absolute risk reduction of 1.3%. So the other way of putting this, which is more transparent and honest, is to say, actually, you're a type 2 diabetic patient at high risk. I'm going to put you on a statin. There's a 1 in 77 chance that you taking this statin will reduce the risk of stroke. Those stats are actually pretty good, to be honest. And I would, in this particular group of patients, I would advocate a statin, but I would translate that risk transparently. And if the patient decided they didn't want to take the statin, then that's fine. I think we have to adopt a patient-centered view, but we need to be more transparent with them. Mismatched framing in medical journals also compounds the issue. So what's interesting is benefits of treatments are often presented as relative risk benefits, and then any harms are then presented as absolute risks. So that, for example, so if treatment A reduces the risk of developing disease from 10 to 7 in 1,000, but increases the risk of disease B from 7 to 10 in 1,000, then the medical journal will report this as a relative risk benefit of 30%, but an absolute harm of 0.3%. It's exactly the same thing. And the reality is 1/3 of articles in the Lancet, the BMJ, and JAMA between 2004 and 2006 actually use this mismatched framing. And this asymmetric presentation of data for benefits and harms is likely to bias towards greater benefits and diminishing the importance of the harms. So in 2009, the World Health Organization bulletin went out from Jed Gigerenzer, who's a director of health literacy, risk literacy in Berlin. And I think this is a really important concept that we need to appreciate. It's an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. I'll give you a case study. So this is a patient that I saw. 49-year-old, type 2 diabetic, overweight man. He's seen in an outpatient clinic just after he's had an emergency coronary stenting, which I was involved in. So he comes for a follow-up appointment, and he reports disabling and persistent chest pain. But the history did not sound typical of it being angina. It didn't sound like his stent had been blocked. It didn't sound like there was a new narrowing in his arteries. But nevertheless, one of my colleagues booked him for a repeat angiogram. I think that was not, I think that was very reasonable to do, just to reassure him. So he has the angiogram, and it showed the stent was patent. There wasn't a problem. And the next thing that happens is he's reassured, rightly so, and he's put on a proton pump inhibitor, which is a drug that we give people who we think have acid reflux. So we thought maybe that was the cause of it. Discharged to a general practitioner, and he was planned to be reviewed a few weeks later by us again. He's then seen in cardiology outpatient clinics, still complaining of the same pain. He sees me, And at that point, his GP has now referred him for an endoscopy for this disabling chest pain. Now, I had, at the time, a colleague of mine had mentioned to me that he had heard that there was one case or something that he'd come across in his career where people taking statins had experienced a kind of persistent chest pain. He also described having muscle aches as well. So I actually advised him stop taking his medication for 2 weeks, because often if people have side effects from statins, in my experience, they're reversible, they disappear usually within a couple of weeks. So he returns to my clinic. He didn't have an appointment. He just turns up at the clinic and he's elated. He says, "Doctor," and this chap was depressed for months because he had persistent chest pain. He said, "Thank you, doctor. After months of misery, my pain has now disappeared, but now I'm worried. My GP says you must never stop your statin or you could die." Now, does anybody have any idea what the risk of death for someone with established heart disease, and he was rightly taking a statin for mortality benefit, what the risk of death would be for him stopping a statin for a day, or even 2 weeks? Any guesses? 1 in 10,000 for 2 weeks, the risk of death from him stopping a statin. Stopping it for 1 day, 1 in 150,000. But this chap had it in his head, he was really worried. Now, anyway. So we'll move on to the diet side now. Has overemphasis on medical treatment detracted from us addressing lifestyle? Well, in the UK, we have a real issue. We have a public health crisis. 60% of the UK's adult population are overweight or obese. What I find perhaps more disturbing is 1 in 3 children by the time they leave primary school, by the age of 11, are also overweight or obese. One of the government reports that was done, the Foresight report, predicted that if we do nothing, 90% of UK's adult population will be in this category by 2050. It's quite staggering. Obesity alone is currently costing the NHS around £6 billion a year, and that's estimated to reach $50 billion by 2050. The total cost of diabetes is much greater, predominantly type 2 diabetes, but overall the cost is around $20 billion, directly and indirectly through lost productivity to the economy, and that's set to double by 2035 to £40 billion. Non-communicable diseases, diet is a risk factor, and I'll come on to how important diet is soon. Have now undertaken undernutrition as the commonest cause of death worldwide. The question is obesity just the tip of the iceberg? And I'll tell you why it is. So I think no one can argue with the fact that when we talk about the hierarchy of different things that are influencing population obesity, it's the obesogenic environment. Processed food is everywhere. It's become unavoidable. Wherever you go, whether it's the gas station, car washes, gyms, health clubs, etc., it's impossible to avoid processed food. Sugary drinks, chocolate bars, crisps, you name it. It's very difficult to avoid. It's everywhere. We have an oversupply of this food. For me, though, the biggest scandal is this. The very institutions that are supposed to be promoting health are actually selling junk food and promoting junk food. And this is important. This becomes has become a branding opportunity for the junk food industry. We know, for example, that in one hospital in London, I found out, one major hospital, I won't name it, there are an average of around 10,000 visitors per week walking through those corridors where they're selling junk food. Think about that. I mean, it's brilliant for the food industry, but not very good for our health. This legitimizes the acceptability of junk food. You have fast food on site. In fact, one study in the United States showed that pediatric institutions that had fast food on site, people who visited those institutions, whether it was visitors or relatives of patients, were 4 times more likely to consume fast food or junk food when they left the hospital than people who had never visited the hospital in the first place. The association with health. We have hospital trolleys loaded with junk food. I've gone on ward rounds after treating people for heart attacks. In fact, this is one of the reasons that I got involved in this campaign. And there are contracts with hospitals that enforce that patients who are even bedbound have trolleys delivered to them which have cans of Coca-Cola, chocolate bars on them, and then you see patients eating this stuff. I'm trying to give them lifestyle advice. One patient came to me. I treated him for a heart attack in the middle of the night. 3 a.m, I got up, treated him for a heart attack. He was very grateful, did the ward round the next morning, tried to talk to him about lifestyle advice. And he said to me, "Doc, how do you expect me to change my lifestyle when you're serving me the same crap that brought me in here in the first place?" And education is ineffective when we're battling against a food environment. One would think that, healthcare professionals should have more knowledge about this, but actually in the NHS, 50% of employees, doctors and nurses, are actually overweight or obese. And this perpetuates a revolving door of healthcare. So, coming back to the food environment influence on our behavior, so there's a very good researcher in Cambridge called Teresa Marteau, and she wrote a very good paper in the BMJ, and this is a very key point, that food choices are often automatic and made without full conscious awareness. So despite wishing to lose weight, we're still tempted to buy that brightly colored chocolate bar at the checkout till. And the food industry know where to place their products for that purpose. We have this oversupply of sugary foods. It's then made worse by junk food industry marketing that target children. Fast food advertising in the United States alone, they spend about $4.2 billion on that. And just to put it in perspective, in the balance of power, for every £1 that the World Health Organization spends in promoting good health, the junk food industry spends £500 in marketing junk food. That's the balance of power that we have and that we're working against. And this is important. You know, there was a survey carried out in England by the School Food Trust, and they revealed that 72% of parents felt that actually this advertising contributed to pester power. I'm sure a lot of parents in the audience have experienced this. Now, what's the food industry strategy that hinders progress for population health? I call it the corporate playbook of big food. And the first thing they do is they focus on personal responsibility. We've heard some great talks. Andreas spoke about this yesterday, that it's your fault, it's bad character. That's the cause of the nation's unhealthy diet. They raise fears that any government intervention is also interfering with personal freedom. But we must remember the greatest public health successes that happened, whether it's safe drinking water, seatbelts in cars, smoke-free buildings, they happen through regulation, not through voluntary agreements with the food industry, which is what we have at the moment. The food industry also, like many businesses, engage in corporate social responsibility. So when the city of Philadelphia was considering a soft drinks tax, a sugary drinks tax, the junk food industry donated $10 million to the local hospital. It's a drop in the ocean for their profits. And surprise, surprise, that sugary drinks tax didn't happen. And then they vilify critics with totalitarian language, calling us food fascists, leaders of the nanny state. I've been called all of these things. Now, this again is something that really irritates me. They emphasize physical activity over diet. Okay, they say it's all about lack of exercise. And I've had debates with various people on this, on TV and in the print as well. But actually, exercise, although I promote exercise as having many health benefits. If I didn't believe it, I wouldn't go to the gym every day and do my 30 minutes. Exercise has a lot of value. However, its link to obesity is so weak, I would say that we shouldn't even use it in the same sentence. We are misleading the public. It is a lie. Physical inactivity and obesity should not be associated with each other at all. This plays into the hands of the food industry, and they've done it very effectively. And one of the other things the food industry have done is they're adopting the very same tactics as tobacco. So we must remember it took 50 years from the first publications of the links between smoking and lung cancer before any effective regulation happened. And that's because big tobacco adopted a strategy of planting doubt, denial, confusing the public, and even buying loyalty of scientists, whatever it takes to protect their only interest, which is profit. And the degree of denialism, even in 1994, the CEOs of every major tobacco company went in front of US Congress and swore under oath they did not believe nicotine was addictive or smoking caused lung cancer. That's the degree of denialism. Now, the association of junk food and sport. We had the Olympic Games in 2012, and I publicly went on BBC in a report I did, and I said it was obscene that in the midst of an obesity epidemic, we have our major sponsors as McDonald's, Coca-Cola, Cadbury's, and Heineken. I mean, yeah, a picture speaks 1,000 words. Okay, so where does diet come into all of this in terms of our health? So according to the Lancet Global Burden of Disease reports, actually diet contributes to more disease than physical inactivity, smoking, and alcohol combined. What about cardiovascular disease? Well, still one of the biggest killers in the world. So the number one cause of death globally, more people die annually from cardiovascular disease than any other cause. At the moment now, we estimate around 20 million people will die from cardiovascular disease per year, and that's on the increase. Low and middle income countries are disproportionately affected. And around a quarter of these deaths are premature, they occur under the age of 65. But, this is crucial, most cardiovascular disease can be prevented by addressing lifestyle factors: tobacco use, unhealthy diet, obesity, physical inactivity, high blood pressure, diabetes. Now, this is a, sorry, just check. So this is a coronary artery, this is normal, and this is a plaque that builds up over time, okay? So this is a chronic inflammatory process where you have inflammatory cells, cholesterol, smooth muscle cells, and this narrows the artery and reduces blood flow. If it's more than 70% narrowed, that's when you get angina. But what's interesting is the process, you can have a stable plaque here, but the process that, when you have a heart attack, the development of the thrombosis and what we call a rupture of the plaque, that can happen within minutes. So you can have one of these almost like a ticking bomb. It can be quite stable, but it can suddenly rupture. And we don't know why it happens at any particular time, but we know the factors that are involved in this happening, and I'll explain that now. So we know that there are rapid falls in mortality after risk factor changes in populations. And as I've said before, the pathological process that underlies coronary artery disease development can take many years to progress. We know from autopsy studies in children who have died that there have been fatty streaks found in the aorta, so that obviously can start even in childhood. But most cardiovascular events, most heart attacks happen after the age of 60. Heart attack and strokes happen after the age of 60. But the perception is that this process that progresses slowly will also reverse slowly, and that's wrong. There's actually very strong evidence that substantial reductions in mortality can occur even within months of decreases in smoking and within 1 to 3 years of dietary changes. In fact, I would say now, and I'll present evidence for this, reducing your risk of heart attack can happen within months of changing your diet. And that's nothing to do with weight. So when a smoking ban was introduced in 2002 in a place called Helena, Montana, what's amazing is within 6 months, there was a 40% reduction in admissions for heart attacks. It's quite dramatic. And when the tobacco industry started pulling their weight, the law was rescinded, and the levels of heart attack went back to the same as they were before. When we had smoke-free legislation introduced in Scotland in 2006, there was a 17% reduction within a year of hospital admissions because of a heart attack, and also 6% falling out of hospital cardiac deaths. And the reason for this is that passive smoking, actually, within 30 minutes of passive smoking, we know from scientific evidence that it increases platelet reactivity. So when smoking ban was introduced, actually a lot of people who were exposed to smoke before, that inflammatory process actually reduced, and even people who had underlying coronary artery disease, they were less likely to have a heart attack, and that's quite dramatic. We say the same thing that happened for diet as well. Randomized study showed, the DART trial showed that people having a heart attack had a 29% reduction in all-cause mortality within 2 years when they were eating fatty fish as opposed to not eating fatty fish. There's also a trial called the CVD Prevention Policies, which showed the same thing happened with omega-3 within a very short space of time. So this is a very important concept, that these prevention policies and regulation actually are very effective and evidence-based. We have upstream determinants and downstream causes. So for example, in food, trans fats contribute to dyslipidemia, abnormal cholesterol. They make it more atherogenic. Trans fats are still an issue. 50% are hidden in muffins, cakes, biscuits, cookies, wafers. 25% is hidden in fast food, such as popcorn. In the UK, we had the Food Standards Agency with a voluntary policy with the food industry managed to get trans fat consumption down from 2% to 1% by reducing it in food. In Denmark, they had regulations that actually got rid of it altogether, and really that had a massive impact. So in the UK, if we got trans fat consumption down just from 1% to 0% per day, that would actually prevent 5,000 deaths within a year from the adverse consequences of trans fats and save £230 million. Now, this is a fantastic study that was published in the New England Journal of Medicine in 2013 called the PREDIMED study. And it's a randomized controlled trial, and it involved several thousand patients, people who were high risk of having heart attacks. They had diabetes. Majority were women. And what they found was that actually a Mediterranean diet, a high-fat Mediterranean diet, 41% fat, supplemented with olive oil and nuts, actually resulted in a significant reduction in risk of the composite endpoint, heart attack, stroke, or death, by 30% within 4.8 years. So the numbers needed to treat there was 61, which is really very impressive. And what's very interesting as well on this is if you look at these lines of separation between the control diet. Now, the control diet actually was still quite a healthy diet. It was a Mediterranean diet, but there was more white bread and pasta and that kind of stuff, but actually much healthier than maybe the average Western diet. And this is the intervention group, which is a Mediterranean diet supplemented with nuts and also with extra virgin olive oil. There's about 4 tablespoons, at least 4 tablespoons of extra virgin olive oil per day, and about 30 grams of nuts. I've got to be honest, I probably consume about 10 tablespoons of extra virgin olive oil per day. That's probably, 4 tablespoons is 500 calories, so you can do the math there. And it doesn't seem to have affected me, and that's just pure fat. But what's interesting here is that the lines of separation in terms of the event rates for cardiovascular disease happened within months of changes in diet. And this has nothing to do with weight. In fact, the people that benefited most were the people with the highest BMI, and there was no weight loss, significant weight loss. A very good paper published in the BMJ in 2011, done by Darius Mazafarian and Simon Capewell. And what they did, they predicted, now I know you may not agree with all of this, but what's interesting is they predicted, based upon very good high-quality observational data and randomized controlled trials, that if the whole of the US population was to increase their nut consumption by 1 serving per week, that would actually prevent 90,000 cardiovascular deaths within 1 year. To put that in perspective, and it's a pie in the sky, maybe a magic wand, but if governments across the world were to introduce regulations that encourage the consumption of healthy food and decreased the consumption of junk food, that would halve cardiovascular deaths within 1 year from 20 million to 10 million. We need regulation. This is Centers of Disease Control Health Impact Pyramid, and this is just to put all the bigger picture and put things in perspective. So counseling and education has an impact, but it's very small in comparison to actually socioeconomic factors, but probably most importantly, changing the context. We need to make the food environment healthier. That will have the biggest impact on population health. And we know that's happened with tobacco, whether it's smoke-free laws and tobacco taxes, for example, as well. This effectiveness hierarchy is very clear. There's very good scientific evidence to support this. And they're more effective. They reach larger proportions of the population, and they're not dependent on its sustained individual responses. So are we giving the wrong dietary advice? I think we are. So as you've heard already throughout this conference, we know that Ansel Keys' 7-country study really demonized saturated fat, and said increased cholesterol was the main dietary cause of heart disease. This change of dietary advice happened in the late 70s in the US and then in the early 80s in the UK. And we were told to eat less fat and eat more carbs. The food industry has exploited this low fat is good for you mantra, and it's resulted in diets high in refined carbohydrates. I think we need to all agree that the low fat is good for you message, it's not good for you, it's harmful. Okay, we eat more carbs, we need to get rid of that message. The prevalence of obesity and type 2 diabetes has then rocketed. We know that Keys used selective data when there were countries that he didn't use in his data that didn't show the correlation that he wanted. And I think Nina Teicholz has highlighted in her book, and I recommend you read that book, A Big Fat Surprise, that actually Ansel Keys, in the Greek population, he did his samples during Lent when people were fasting and avoiding meat. So again, that's obviously slightly misleading. And what's little known is actually Ansel Keys received research funding from the sugar industry as well, which is very interesting. Right, so what about saturated fat and cholesterol? Well, we know it increases LDL, but it also increases HDL to an equal degree, and also it increases the large type A particles of LDL, which are less atherogenic, whereas refined carbohydrates increase the type B particles, and Jeffrey Gerber spoke very well about that yesterday. It has little effect overall on total cholesterol to HDL ratio, and that's actually more predictive of having a cardiovascular event. The source and type of saturated fat may also be important, with some suggestion that dairy products may be protective. I'll come into that shortly. And this is also very interesting. So a reanalysis of something called the Sydney Heart Study showed that heart attack patients that replace butter with safflower oil, which is high in omega-6, although they had a 13% reduction in their total cholesterol, they had increased mortality. So I put all of this together in a piece that got a lot of attention called Saturated Fat is Not the Major Issue in the BMJ. Following that, there was a study which was done out of Cambridge Medical Research Council to see whether these claims were true, and let's look at the data. And they found actually the current evidence does not support guidelines that restrict the consumption of saturated fats and encourage the consumption of polyunsaturated fats in order to prevent heart disease. Another interesting finding from this study is they found that one particular type of saturated fat, margaric acid, actually, which is a dairy fat, was associated with reducing the risk of cardiovascular disease. And that was published about 6 months after my article. Could better dietary assessments also help clarify the association? Well, there was another study published a few months later in The Lancet looking at the association between saturated fat consumption and type 2 diabetes. And what they found, it was quite an extensive study. It involved around 12,000 people across Europe. And what they found, actually, is that different saturated fatty acids in the blood had different effects in terms of type 2 diabetes. And just to conclude on those, I'm not going to go into a lot of detail, but the most important points is they were associated with different risks of type 2 diabetes. They're not a homogeneous group. There were actually scores of different types of saturated fats. Very few people know this. And you need to discriminate between the subtypes. And the take-home messages were that actually where the saturated fat comes from is important. So if they come from dairy products, so full-fat yogurt and cheese, for example, those saturated fatty acids were associated with a reduction in risk of type 2 diabetes. And therefore, we should actually place more emphasis on foods and on diet patterns rather than demonizing saturated fat, for example. And that was one of the take-home messages from this study. Okay, what about statins? So we know there is a multitude of randomized controlled trial data that shows there's reduced mortality from taking statins if you have established heart disease. If you've had a heart attack, it will reduce your mortality. The benefits are there. But that benefit is around 1 in 83 over 5 years. Okay, numbers needed to treat. So if you've had a heart attack and you take a statin for every day of your life, then in 5 years there's a 1 in 83 chance that taking that statin will save your life. That's proven from randomized controlled trials. There's a weaker, but still some benefit if your risk is greater than 20% of developing cardiovascular disease in 10 years. Now, this article was published in the BMJ. It's a brilliant paper, actually, by a Harvard professor called John Abramson that you may have heard about. There's a lot of controversy around it, and I'll talk about that briefly. But there was no controversy about the fact that what he did was he analyzed an independent analysis. It wasn't an industry-sponsored analysis, and that's key. An independent analysis to look at if people had a 10% risk, because a lot of discussion about lowering the threshold for people who should take statins, what were the benefits? And what they found was if you have a less than 20% risk of cardiovascular disease, taking a statin will not prolong your life. It will not in any way prolong your life. It does not reduce mortality. There's about a 1 in 140 chance that it will prevent a non-fatal heart attack or stroke, but a similar risk of developing type 2 diabetes, but no overall mortality benefit. And then you get into the whole issue of side effects. Now, in this paper, and I also cited this in my paper, we looked at one very large, uncontrolled observational study, and that showed about 17.4% of patients had a statin adverse effect documented. There were some people that weren't very happy about this, and one particular professor who has been a champion of statins for many years actually asked for both this article and my article to be retracted because we had actually exaggerated the side effects on statins. He, in fact, said that actually there's only 1 in 10,000 people who have a serious side effect from statins based upon his data. But for me, it's about quality of life, not just about whether you have a very serious side effect. So what's interesting, though, is Pfizer, one of the drug companies that has marketed atorvastatin, actually on their patient leaflet say common side effects affect up to 1 in 10. So the drug company's own leaflet say common side effects may affect up to 1 in 10 people, and they include inflammation. Well, you can read them. Okay, so I don't think any of these are things that we want to have. Okay, they're often reversible in stopping the drug if you get them. They're not life-threatening, but they certainly interfere with the quality of life, and I've seen that with my patients. So in the UK, our National Institute of Health and Care Excellence, NICE, then, interestingly, even after all of this, then came out with a recommendation saying that basically doctors should prescribe statins to those with a risk of 10%, even though that data is quite compelling to suggest maybe that isn't a good idea. And several of us, I was included, and a few other well-known people actually wrote a letter, it got a lot of media publicity around this, to the Secretary of State for Health, saying that we didn't think this was a good idea, and these are the reasons we gave. One, it was medicalizing 5 million healthy individuals. The question was, does treatment of elevated cholesterol in people who are otherwise healthy, does it reduce mortality or prevent any other serious outcomes? As we know, this actually isn't the case based upon the independent data. The other question is, what are the rates of adverse effects associated with statin treatment in healthy people? And it's quite clear that if you're a healthy man, even if you've got elevated cholesterol, taking a statin will not prolong your life. There's very good evidence for that. The other aspect of this letter that we wrote, which I thought was very interesting, is that the studies that have come from pharmaceutical industry, all the different major statin trials, have shown that what's very interesting, the rate of adverse events in the drug actually almost identical to the placebo, which suggests that people are imagining the side effects. And they're different in every trial, but this difference actually shows, the adverse effect rate of statin is always very similar to that of the placebo. However, placebo adverse effect rates range from 2.7% to 80.4%. So people taking a placebo, 80% of those people that came out of the trial didn't feel very good on them, and it was identical to people taking the statin. So we thought that was a bit odd. Don't know what you think. Hidden data. So without access to the raw data, which is kept commercially confidential by the pharmaceutical industry, it's difficult to understand how these adverse effects also relate to placebo so precisely. The data that NICE were using on driving the statins comes almost entirely from pharmaceutical company-funded studies, and these studies are not available for you by independent researchers. And the very organization that has put out these studies on the benefits of statins, they have these commercial, agreements with pharmaceutical industry, and they have received hundreds of millions of pounds in research funding over many years on statin trials. So there are a few question marks there. I think that I think we needed to get out there to the public and also to the Secretary of State for Health. So industry bias comes in there. We know it's very well established that industry-sponsored studies systematically produce more favorable outcomes than non-industry-sponsored studies. There was one non-industry-sponsored study done on statins in primary prevention, so people who are otherwise healthy and low risk. And what that found was there was no benefit in reducing mortality. And that was the only one independent study, a very large study that was done. This then got picked up by the General Practitioners Committee that represents all GPs. And this was fantastic because they as a group decided that because of other things that have happened with various drugs in the past that have then proven not to be effective, they actually passed a motion in their conference saying that not to recommend statin therapy until we have data from all the clinical trials. Now, conflicts of interest, there was another thing that we discovered, is that 8 members of the guideline panel of NICE, of those 12 members, I'm not saying that they'd done anything wrong, knowingly wrong, but I think there's a bias here. They had financial ties to the pharmaceutical companies that manufacture statins. And we felt as a group that parties with industry conflicts should not be participants in generating recommendations regarding drug use that will influence medical care across the whole population. Does anyone disagree here with that? The other aspect, of course, is that the unit in Oxford that have been putting out, obviously, these studies, they have commercial agreements that don't allow us to see the raw data. And they've received a lot of research funding over the years. So we felt all of this added up. And we called for the release of this raw data to be reviewed by independent researchers such as the Cochrane Group as well. So, this wasn't just a few extreme mavericks. There's some very reputed and respected people who signed this letter, which include the President of the Royal College of Physicians, the former Chair of the Royal College of General Practitioners. And obviously myself, I was in there somewhere. The British Medical Association then also passed a motion saying that this meeting believed, and this is 95% majority, that any advisory committee of NICE, when guidance on any drug is issued, it must be made clear that none of the members must have a financial interest in the pharmaceutical companies that are manufacturing the drug. And this was passed in June 2014. Yet NICE still carried on with their guidance. So to conclude on this aspect of the talk, saturated fat is not the major issue. The source and type of saturated fat is important, but we need to focus on foods and diets with proven benefit to reduce cardiovascular events and mortality. The Mediterranean diet still has the best evidence base. Focusing on cholesterol lowering alone has been counterproductive. Professor Rita Bredberg, professor of cardiology, University of California, San Francisco, and editor of JAMA Turner Medicine, said in a documentary, "Who cares about cholesterol lowering if it doesn't benefit the patient?" But we need to embrace both pharmacotherapy in the right groups and address lifestyle. One is not a substitute for the other, but we need to know the evidence properly. It needs to be communicated transparently. And of course, we need all the data to be made available to make more informed decisions and more robust studies to determine the incidence of side effects that interfere with the patient's quality of life. So a little quiz to finish off. Numbers needed to treat for heart disease. Okay, for mortality alone. Okay, if you've had a heart attack, and you take aspirin every day, there's a 1 in 100 chance that that is going to save your life. I think those are pretty good odds. Aspirin is a relatively safe drug. It's cheap. Side effects can happen, but generally those are pretty good odds. A statin, if you're high risk, you've had a heart attack, there's a 1 in 83 chance if you take a statin every day for the rest of your life. If you've had a heart attack, there's a 1 in 83 chance over 5 years it will save your life. What about aspirin and statins at low risk? Well, if you haven't had a heart attack, actually it does not improve your prognosis. It does not prolong your lifespan. Coronary stents during a heart attack. If you're having an acute heart attack, then there's a 1 in 40 chance that having a stent will save your life, and that's even within a month of having that heart attack. So that's very strong evidence. How about coronary stents at any other time? Well, it's infinity, because if you haven't had a heart attack, if you've got stable angina, it's not going to improve your prognosis. So what's the most powerful coronary intervention tool we have? More powerful than anything else. Mediterranean diet. Numbers need to treat 30. Now, this is very powerful information. This is information that we've sequestered, we've held back. And for me, this is a symptom of a broken system, where we've held back this information. When everybody in the room knows that a coronary stent for stable coronary artery disease is not going to improve your prognosis, yet a Mediterranean diet is the most powerful coronary intervention tool we have. When everybody knows, the doctor, the patient, the receptionist, the nurse, the Secretary of State for Health, the porter, when everybody knows this, then we have real transparency. And transparency leads to accountability, and that leads to the best quality health that we need more than ever. To finish on this quote, the preservation of the means of knowledge among the lowest ranks is of more importance to the public than all the property of all the rich men in the country, said by John Adams, the second US president. Thank you. Yeah.